Welcome back, everyone. And let me introduce our next speaker, who is Dr. Caroline Hall from University of Colorado. Welcome.
Hello, I'm Caroline Hall, and I'm a pediatric GI doctor and a researcher at University of Colorado and Children's Hospital Colorado. And I'm excited to be here today to speak with you about creatine supplementation for patients with inflammatory bowel diseases, a scientific rationale for a clinical trial. I have no disclosures relevant to this talk. As an outline, I'm going to start by introducing you to inflammatory bowel disease. Next, I'm going to discuss the research findings regarding the role of creatine in intestinal function. And last, I will review the clinical trial plans for our creatine supplementation clinical trial. So starting with the introduction to inflammatory bowel disease. So inflammatory bowel disease, or IBD, is a chronic inflammatory disease of the GI tract. It affects about 1 to 2% of US adults and is found throughout the world in increasing incidence. You can see that the primary groups of people that are involved in fact have this problem are from the United States, Canada, Europe, and Australia, but numbers are increasing throughout the world. So presentation of this disease can occur at any age. However, the peak of incidence is between the ages of 15 and 30, and that is part of why, as a pediatric GI doctor, it is something that I see and study. So inflammatory bowel disease, or IBD, is made up of 2 different disease processes, Crohn's disease and ulcerative colitis. For Crohn's disease, you can have inflammation anywhere from the mouth to the anus and scattered throughout, whereas in ulcerative colitis, the inflammation is only found in the large intestines or the colon. Additionally, we see that there are differences when you look at the tissue as well. So in a normal tissue, you see normal folds of the tissue. However, in our IBD patients, you see significant inflammation and distortion of the lining of the digestive tract. In Crohn's disease, you can see what we call transmural inflammation, so inflammation throughout the lining of the intestine, whereas in ulcerative colitis, the inflammation is only found on the surface of the intestine. And right now, IBD therapeutics are mostly focused on systemic immunosuppression. These medications come with increased risks for malignancy and infection. Many of these therapies require infusions or injections to administer, which are not ideal. And lastly, unfortunately, the highest remission rate we get in any of these medications is about 30 to 40%, leaving a significant portion of our patients who are not controlled by these medications. So that leaves us with a significant need for therapeutics with fewer side effects, easy administration, and increased efficacy. The pathophysiology of IBD is multifactorial in that there's no one gene that results in patients developing IBD, but likely contributions from the immune system, genetics, environmental factors, and microbes come together to cause this chronic inflammation, which results in inflammatory bowel disease. In regards to the immune response, there are several components, including the epithelial barrier and immune cell function. In regards to genetic factors, there are a number of different genetic factors that have been associated with IBD, primarily focused on immune regulation. Microbes seem to be dysregulated in inflammatory bowel disease, as we see dysbiosis in patients with IBD. And lastly, there appear to be some environmental factors, as you can see that diet and other exposure to different medications likely contribute to the development of IBD. The intestinal barrier is the first step in immune regulation in the GI tract. It plays a very important role of keeping food and bacterial antigens in the lumen of the digestive tract and away from the immune cells, which can cause inflammation. And when this barrier is disrupted, the bacteria and other products can come in contact with immune cells and cause chronic inflammation and thus inflammatory bowel disease. Maintaining a strong epithelial barrier is very energy dependent. It requires continuous shuttling of tight junctional proteins to the location between the cells, which creates that strong barrier and keeps items in the lumen there and not in contact with the immune system. These proteins are kept in this location in conjunction with actin scaffolding that holds them in place and allows for frequent shuttling of the proteins in and out of the membrane. And we have long thought that likely there's an energetic component to inflammatory bowel disease. More than 40 years ago, there was a paper which discussed the potential of ulcerative colitis being an energy deficiency disease. They thought this based on research which showed that colonic cells from patients with ulcerative colitis demonstrated increased dependence on glycolysis, decreased beta oxidation, and this profile was in fitting with a stressed or energy deficient cell. So this leads us to our current research regarding the role of creatine in the intestine. What we know about the digestive tract is that there is a lot of energy used and expended. In addition, we know that there is a key role for hypoxia and the role of hypoxia on inflammation in the intestines. As you can see, even in control tissue that has been stained for a hypoxia probe, there is some physiologic hypoxia found at the surface of the intestines in a mouse. And in the setting of inflammation, specifically TNBS colitis, you can see that the amount of hypoxia is increased significantly and spreads deeper into the tissue. Knowing this, Dr. Glover, one of my collaborators, was able to identify a relationship between hypoxia and creatine machinery expression, namely CKMB and CRT were all regulated by hypoxia. So this all led to our driving hypothesis, which is that given the high energy demands of the intestinal barrier and the altered regulation of creatine pathway in the setting of hypoxia, could the creatine pathway contribute to epithelial cellular function and be dysregulated in inflammatory bowel disease? So in order to answer this question, we first wanted to assess relative expression of the creatine transporter and in IBD. And so we took biopsy samples from patients with IBD as well as healthy controls and looked for relative expression of the creatine transporter. There we saw that there was indeed a significant decrease in the creatine transporter in ulcerative colitis patients. And when we separate out the IBD patients based on disease activity, we interestingly found that in Crohn's disease patients with inactive disease, there was again some significant decrease in the creatine transporter expression relative to controls, but this was lost in the setting of active inflammation, which may be representative of infiltrate of immune cells into the tissue in that setting. Additionally, Dr. Glover found a similar finding in the expression of CK-MYT1, CKB, and CKM in Crohn's disease and UC patients. So we wanted to identify the localization of the creatine transporter in epithelial cells. And we found that when we co-stain intestinal cell line with a marker for the tight junction, Z01, as well as the creatine transporter, that these two proteins are at the same level within the cell. not exactly co-localized, but adjacent to each other. And when we looked in tissue from healthy humans, we saw a similar phenotype where we would see expression of the creatine transporter in the mid portion of the cell, which would coincide with tight junction localization. So that we then wanted to determine if the creatine transporter has an impact on epithelial barrier function. And so in order to do that, we used siRNA knockdown of the creatine transporter in epithelial cells in order to reduce creatine transporter expression. And we were able to establish 2 cell lines in addition to our control, one that had a partial knockdown and one that had a more full knockdown. And this is just visualized here in mRNA as well as in protein. And when we looked at the amount of creatine within the cell by HPLC, we were able to see that there was indeed a 50% reduction of intracellular creatine in our full knockdown cells as compared to the control, which is fitting with the loss of the creatine transporter. So we next wanted to determine if this loss of creatine transporter would have an effect on intestinal epithelial function. And we wanted to do this by checking the barrier activity. And the way that we do this experiment is we plate our epithelial cells on a permeable membrane and then measure resistance across this membrane over the course of several days. And in this study, increased resistance means increased barrier. So an increased tier value means that the barrier is stronger. And in this, you can see that our control cells have a very nice and robust increase in their barrier. However, our partial knockdowns have an intermediate level of barrier development, and the full knockdowns have the lowest level of barrier development, suggesting that there is a relationship between creatine transporter expression and barrier formation. We also wanted to confirm this finding by another evaluation of barrier function with a FITC flux assay. And in this study, we grow the cells again on a permeable membrane and then add a FITC labeled sugar molecule dextran to the top component and evaluate for the ability of the sugar to pass through the cells. And we measure that ability over time. And in this study, a lower value means a stronger barrier because the dextran is not able to pass through. And so you can see in our control cells, there's a very low amount of the FITC dextran getting through over time. And then with each incremental decrease in the creatine transporter, there's more of that passage, suggesting again that the barrier is dysfunctional in these cells. Interestingly, we went on to use some creatine knockout colloids. So these are primary cells isolated from a creatine transporter knockout mouse and then grown in culture to replicate primary colloids. And you can see that they indeed lack the creatine transporter, both in mRNA and message. And then when we set up an experiment again to look at barrier, we saw that our control colloids were able to develop a very strong barrier, and our creatine transporter knockout colloids, again, like our cell culture experiments, were not able to develop that barrier. So we wanted to better understand why these cells are not able to form a strong barrier. And so we looked to the tight junction protein expression. And one thing for you to know is that there are many different types of tight junctional proteins. Claudin-1 is a tight junction protein that results in increased barrier activity, whereas Claudin-2 is a pore-forming tight junctional protein. ZO1 and JAM-A are also important. And we saw that there was a decrease in expression in Claudin-1, which makes the barrier tighter, and an increase in Claudin-2, which makes the barrier leakier in these creatine transporter knockout cells by message. And the finding with the Claudin-1 was also confirmed with protein and not seen as much with the Claudin-2. Interestingly, when we go back to those human patient samples, we were able to confirm this relationship in vivo as well. So when we look at the relative expression of the creatine transporter and Claudin-1, the tight junctional protein, we saw a positive relationship between these two factors on a per patient basis, and a negative relationship between Claudin-2 and the creatine transporter in that same patient population. No relationship was seen with CO1. In addition to overall expression, we also saw that the tight junctional proteins seemed to be mislocalized in our epithelial cells. So these are in tissue culture cells. In a normal tissue culture cell, the tight junctions should look like this chicken wire appearance, nice, strong lines that you see for ZO1, Claudin-1, and Claudin-2. However, in our knockout cells, you can see that there's a lot of intracellular staining and more globular staining throughout the tissue, throughout the cells, suggesting that these tight junctional proteins are not able to localize to the tight junctions as they normally would. And we postulated that this would be due to an inability for actin to polymerize well in the setting of decreased energy allowance. And we do believe that that is the case, given what we see with significant actin polymerization on the control cells and a loss of actin polymerization in the creatine transporter knockout cells. Another very energy demanding part of epithelial cell function is wound healing. And so we wanted to investigate if the creatine transporter knockout cells would have difficulty healing a wound. And so we did this by using a wound healing assay where cells are plated in a monolayer and then get a uniform scratch and then are watched over time to evaluate for wound healing ability. The gray area is the area outside the wound. The yellow area is the area that's been healed, and the orange is the area that remains unhealed. And you can see if you compare the control cells to the creatine transporter knockout cells, that the wound remains much larger in the creatine transporter knockout cells as compared to the controls. And this is quantified here to be statistically significant. So if the loss of the creatine transporter results in a decreased barrier function, we wanted to determine if enhanced creatine transporter expression would result in the opposite effect or improved barrier function in wound healing. And so we overexpressed the creatine transporter using a lentiORF. And we're able to see that indeed, if you have more creatine transporter, you're able to achieve a higher barrier at an increased rate, which is measured by both our TIR experiments, as well as our FITC dextran flux experiments, where in this study, a lower value represents a tighter barrier. In addition, although not statistically significant, we saw an effect of the creatine transporter overexpression with a reduced amount of open wound residual at the end of the experiment, as you can see here. We also wanted to profile the metabolic status of these cells. And so we did a seahorse analysis to evaluate glycolysis and mitochondria at baseline and under stress conditions. And we were able to see that the control cells, when placed under metabolic stress, were able to increase mitochondrial respiration and glycolysis just as you would expect. However, in our creatine transporter knockout cells, they were able to increase glycolysis, but not to increase mitochondrial respiration, as you can see here. And this is suggestive of a reduced metabolic potential in regards to respiration in these cells. And we think it makes sense given the key role of creatine in shuttling energy throughout the cell and may have an impact on mitochondrial activity. We also wanted to evaluate for the ability of the cell to compensate by increasing creatine production enzymes AGAT and GAMT within these cells. And we did see, although a non-statistical increase in both AGAT and GAMT in our human intestinal cell line, but we did see a statistical increase in AGAT in the creatine transporter knockout collonoids. and a lesser effect on GAMT. So lastly, we wanted to evaluate for the protective effect of creatine in a mouse acute colitis model. So we used the TNBS acute colitis model in mice that were either fed a 2% supplemented creatine chow or normal chow. And you can see in this experiment that the mice fed the normal chow lost significant body weight throughout the course of the experiment. And this did result in mouse death throughout that experiment. However, those mice that were given the creatine supplementation were able to maintain their weight in the same fashion as those who got no TNBS at all and had no mouse death. Additionally, if you look at the histology of this experiment, you can see that in the control chow mice, those treated with TNBS had significant injury to the lining of their digestive tract, whereas in those treated with the 2% creatine chow, they had significant protection of their histology. And this is quantified here in two different scores: an inflammatory score, which measures immune cell infiltration, as well as the injury score. So in summary of our research to this point, we do believe that the creatine pathway is very important to intestinal epithelial barrier function and wound healing, and that creatine supplementation can be protective in acute models of colitis. So in a healthy intestinal epithelium, creatine is taken up and phosphorylated by creatine kinases and shuttled to areas of increased need in the cell, specifically to the tight junctions where actin polymerization is a very high energetic demand. However, in inflammatory bowel disease, as we've discussed, there's a loss of creatine transporter as well as a loss of creatine kinases, which means that there's less total creatine as well as less phosphorylated creatine in these tissues, which means that energy is less well shuttled within the cell and that there was significant decrease in barrier function as well as wound healing. Interestingly, there has been a case report of the use of creatine in patients with IBD. So there was a 22-year-old patient with Crohn's disease who was on creatine at the time of his diagnosis and had very mild disease with minimal inflammation. And you can see this is an endoscopic view with some areas of redness and little bits of ulceration, but a relatively mild amount, as depicted here with a Crohn's disease endoscopic score of 4. However, at the time of this diagnosis, the patient and the provider decided to stop his creatine in order to use a medication well known in inflammatory bowel disease called mesalamine in order to try to treat this inflammation. And what was seen subsequently is that the patient developed more clinical signs of inflammation, as well as had endoscopic worsening with larger ulcers and significant inflammation with a Crohn's disease endoscopic score of 7. At this point, the patient requested going back onto the creatine and stopping the mesalamine, given the relative worsening since that change, and subsequently found that they had significant improvement in their symptoms, as well as improvement in their visualized endoscopic appearance. So you can see here, this is after being back on the creatine supplementation. There is one small ulcer here, but otherwise pretty well appearing with an overall Crohn's disease score of 4. So this takes us to our IBD creatine supplementation clinical trial plans. So we have developed a clinical trial that has been IRB approved, and we are currently starting to recruit patients for, which involves ulcerative colitis patients with mild to moderate disease severity. We plan to treat these patients with creatine supplementation 14 grams per day or placebo daily for 8 weeks. Patients can continue to be treated with mild IBD medical treatment, including mesalamine or thiopurines. We will evaluate for endoscopic response either before the study and after treatment. We will also collect blood and stool specimens. For this trial, our primary outcome is endoscopic and histologic improvement. And that will be assessed given those camera scope studies that are done before and after the treatment course. Secondary outcomes that will be included in the study include quality of life, as assessed regularly through serial administration of validated disease-specific questionnaires. We also be looking at inflammatory laboratory tests, both from blood work as well as stool samples. We will be evaluating for intestinal barrier function. We will also evaluate for creatine and CK levels in the blood. And we will evaluate for microbial changes throughout the course of the creatine supplementation. We anticipate that this trial will give us some information which will allow us to evaluate the feasibility of creatine supplementation in IBD, as well as determine some preliminary data regarding efficacy. We will use this data as basis for longer treatment clinical trials, creatine monotherapy clinical trials, and creatine and metformin clinical trials. The metformin part of that potential future direction is there given its role in as an AMPK activator, which is a key energetic support for cells. And maybe combining these two factors together would be an energetic support that is needed for inflammation seen in IBD. With that, I would like to thank the co-authors of the summary about the scientific rationale for creatine supplementation in IBD, which include Sean Colgan, Theo Walleman, and Louise Glover. I'd also like to thank my research assistant, Emily Murphy, as well as my clinical trial co-PI, Mark Garrick at the University of Colorado. I'd also like to thank my funding sources, and I appreciate your attention and your time.